Dr. Decker, do you mind just kind of describing what you see on these three different X-rays that we have here?
Yeah,
And just maybe even, if you think they are stable versus unstable, just looking at what you have now. And I know this is an incomplete series for all three of these, but just what your thoughts might be.
yeah, absolutely. So let's start over on the left there. I'm looking at you got what appears to be a cementless stem and cementless acetabular component, and you see what looks like a fracture in the proximal aspect of the femur in the greater trochanteric region through what appears to be a lytic lesion. And there appears to be some lysis on the medial aspect of the femur as well around the calcar. And when you see that, right away your suspicion is for eccentric polyethylene wear in an older component because you have these lytic lesions, which that's somewhat what it appears to be on that X-ray. But that femoral head doesn't appear to be sitting center in the acetabulum. Now that's interesting because that stem from what you can possibly see on that X-ray. This is why it's important to know what and identify your implants. This appears to be a cementless stem with a metaphyseal ingrowth or on-growth surface. That fracture does go through that area, but just distal to where that fracture is, you can see where there's still on or ingrowth surface there that appears to have a pretty good interface with the bone. There's no radiolucent line there. So suspicion in an injury like that is that that's probably still a stable stem. The middle radiograph, again, similar, this is cementless femoral and cementless acetabular components reasonably aligned, and the fracture is just at the distal tip of the stem there. It does not, and it's a transverse fracture, almost looks like a high energy type injury. This is usually encouraging for being a stable implant. As a stem like this, you can see there's that proximal surface that appears to be where the fixation is, has no disruption in it, and the pattern would imply that there's probably not a spiral or some type of other fracture line into that area. So it's probably, although no guarantee, a stable stem. And then the one on the right is the more difficult one. This is what appears to be an ML, what we were talking about earlier, an ML taper stem, where the real fixation comes from making intimate contact with the calcar medially and the lateral cortex. And you can see pretty well in that stem where the ingrowth or on-growth surface stops. That fracture, though it looks like it's at the distal tip of the stem, you can see it looks like it goes up the posterior cortex there quite a ways. And depending on how this was put in, the ingrowth surface appears to be distal to the neck cut or calcar. So though it could have been put in there or it could have subsided into that position and become fixed over time, assuming it was put in where the neck cut was, that looks like a potentially subsided stem. So high suspicion for a loose implant there, though again, you'd have to confirm that intraoperatively.
Yep. I mean, no matter how hard I try, if I get someone, who's been doing this for however long, they always find something that I didn't see. Like I might get it right and be like, yeah, that's most likely unstable, right? We're still going to test it intraoperatively, but I bet that's unstable. But like say that first picture, me and Cody do questions together sometimes. He
Mhm.
probably recognized that the wear around the femoral head was like it's eccentric in the cup. I totally did not see that. I just
Yeah, it's hard.
totally missed that. Yeah. So that's why I like to hear, our guest thoughts on these things because it helped me kind of point these things out next time. Now I know to make sure you look there. That's one of the things you got to look at as well.
Absolutely.